Hi, this is my patient Jim, and we're going to show you how to do a LPN level shift assessment. So you might want to pull out that paper from the mod to do a physical assessment. I'd go in the room as always and knock on the door, wash my hands, introduce myself. Good morning, Mr. Smith. I'm Lisa. I'll be your nurse today.
Hello.
Hello. What I'd like to do is check you over here a little bit. You always explain what you're going to do before you get started. All right. Now I can see that he's conscious, and we'll start with him identifying himself. Can I have you state your full name, please?
James Smith.
James Smith. And when's your birth date?
August 31st.
And what would you like to be called?
Jim.
Jim. So many times people have a legal name that is not what they go by, so you do want to verify what he's most comfortable with. Next thing I usually check, because it's easy to forget, is the orientation level. He's conscious. I asked him his name, so I know that he's oriented to person, place. Can you tell me what city we're in, Jim?
Peosta, Iowa.
Great.
August.
Is this August? When somebody's hospitalized, I never like to ask them the exact date to assess time, because that's hard to keep track of. So I keep general as far as month or year. All right? And then I generally ask, are you having any discomfort at all right now? Good. Pain level 0 right now. Okay, then if we start from head to toe, usually there's a subjective piece as well as an objective piece with most areas. So I'm going to first of all raise the bed here a little bit, Jim. That's for my comfort and my back as much as anything. I see that he has an IV going, so we have to check the right rate, the right solution right off the bat. Okay, so let's check the hair here first. Make sure hair evenly distributed over scalp. What we really look for here is if there's gross malnutrition, you might notice something. If somebody came in for a fall, you may see a laceration maybe, or if there's a chance that he may have been exposed and infested with head lice or something. So it's good just to take a quick look and see. Then I get out my pen light and start from head to toe. All right. I'm going to have you look straight ahead, and I'm going to assess his pupil response. So I separate here so that we can keep the light to one eye and the other. I start with this eye. The first time I put the light directly, I should see that pupil constrict. I look at this eye, it constricted, I know he's got a response to direct light. Now, I'm going to put the light in that same eye, but this time I look in this eye. This should also constrict, and that would be that he's got consensual response to light. And it did. Okay, now I'll do the same thing. This time I'm looking at his right eye, direct, and then his left eye has consensual. All right, now I want to assess accommodation. He can follow any object from far to near, and his eyes should come together. You do not need to have the light turned on for this part. Can you just follow this pen light for me, Jim? Boom. All right, they did come together. Now, before you put the pen light away, check the rest of his ears, nose, mouth. Just checking the ears, see if there's any obvious drainage. And then I ask him the question. Any changes in your hearing at all that you've noticed?
Nope.
All right, I'm going to check the nose, see if the septum is midline. Looks fine. Any trouble breathing, Jim, with your nose one side or the other? Great.
No.
Can I take a look in your mouth? Mucous membranes look moist and pink. Can I have you smile? Good. And can I have you frown? Good. And how about your tongue side to side? Stick your tongue out side to side. Great. What I'm looking for here is any kind of facial droop that he might have as a result of maybe an old stroke. That might be a chronic finding or something new going on. All right. Now, my lights are still dim a little bit. I haven't really turned them up since I've come in, so I want to take a look. Jugular vein distension is something that's noted on the assessment. What I'm looking at is his jugular vein. The bed should be at 45 degrees for this and in oblique lighting. If he's got some type of chronic or heart disease, that would be pulsating. All right. So now I might turn my lighting up a bit. Check his skin color, that it's pink or pale. And then I'm going to check skin turgor. And there are two places you can do that. Generally, I just, catch it on the chest here. And his skin turgor is elastic. It goes right back into place. Sometimes if people are older, not the best nutrition or hydration, the skin will stay pinched up like that. Okay. All right. I would check his blood pressure, pulse rate, respirations, temp at some point, either the beginning of the assessment or I would do that now. I'm going to listen to the heartbeat to assess the rhythm or any abnormal sounds and the heart rate. I'm going to follow down to the 5th intercostal space, midclavicular line, to find the point of maximum impulse at the apex of the heart. Now if I'm counting, I'll count for a full minute. And I'm assessing the rhythm. Is it regular or irregular? Are there any extra sounds? Right. Now I would assess pain level. Any chest discomfort at all, Jim?
When I cough.
When you cough. And where is that pain?
My ribs.
In your ribs? Each side?
Yes.
Equal? And can you give me a number on a scale of 0 to 10?
2.
2. You want to get an intensity level, and then also if we can get a word to describe it. We have the location, the intensity level, and what word would you use to describe that, Jim?
Dull and achy.
Dull ache. All right. Now I'm going to listen to lung sounds, anterior lung sounds. It's down a little bit more. Okay, so take deep breaths in and out every time I move. Start just under the clavicle. And I'm avoiding the sternum. Okay, and there are 8 spots on the front that we listen. Always go side to side to compare. There's 6, 7. One more deep breath. All right. Now I've listened to the lung sounds. This is when I ask him the questions. Do you feel short of breath at all?
No.
How about when you get up to the bathroom or go for a walk?
Sometimes, yes.
Okay. So often people are comfortable at rest, but for him I would say he has shortness of breath with exertion. Then you want to ask the cough. Are you coughing at all?
Yes.
All right. And then we need to know, is it productive? Are you coughing anything up at all?
Yes.
And then what color is it?
Yellow.
Okay. So he has a productive cough of yellow phlegm. He could be non-productive cough as well. Now, as I move down, I'm going to assess elbows, any bony prominences for any redness or erythema. Now I see his IV here, so I'm going to assess his IV site. Color, it's nice and pink like the rest of his skin. Temperature, go directly over the insertion site. That feels the same. Okay, there's no edema around here that would indicate any infiltration. I see no drainage. This feels nice and dry. And are you having any discomfort at all around this IV at all?
No.
Great. And it looks like it was just started yesterday. So that's good for 72 hours, unless we have other signs that are concerning. Okay, and now as I move down, I'm going to assess his peripheral circulation. I check the radial pulses. Now, they're strong and equal bilaterally. I'm going to check cap refill. Is brisk. Now ask him sensation. Do you have any numbness or tingling in your hands at all?
No.
Now I'm going to assess strength. Cross my fingers like this so that it doesn't hurt if you've got a strong grasp. My knuckles together. Good. It's nice, strong hand grasps. Now if he was in here for a neurological reason, I might want to do a more extensive, with the strength and movement. I'd have him push down. Good. Now pull back. Good. And then I would do that also on this hand. You always want to compare side to side to make sure there's no weakness one side or another. Okay, now I go back to the torso and I'm going to check his abdomen. I'll lower the bed. Not completely flat. Sometimes we want it fairly flat. But if someone's got an abdominal incision or something, we may cause pulling there. So I'm going to take a listen here. All right. So first of all, I'm going to look down just a little bit more. Okay, he's got a flat abdomen. Now I will auscultate. Start at the right lower quadrant. I hear bowel sounds, but I want to listen a little bit longer to see the frequency. Okay, then I'll move. Okay, I hear bowel sounds present, active times 4 quadrants. Now I'll palpate. I'm feeling for any masses, and I'm watching him to see if he jumps, and then I ask him, do you have any tenderness at all in that area when I push there? Good. Now's the time I also assess the subjective data. Do you have, when was your last bowel movement?
Yesterday.
Yesterday, great. Anything unusual with that?
No.
Okay, and how about your appetite?
I haven't been eating much.
You haven't been. Have you been nauseated or just a poor appetite?
Not hungry.
Just not hungry. Okay. Now, if he had a Foley catheter, I would be assessing that now as far as the, make sure the line is patent, and then I'd be assessing color and clarity of the urine. Since he does not have a catheter, I would just ask him, are you passing urine all right?
Yes.
Any burning when you go or any difficulty?
No.
I'm controlling urine? Great. All right. I'm going to take a look at your feet here. Yeah. And again, the whole time I'm inspecting his skin, looking for any areas of redness or breakdown. Okay, I'm feeling the calves for any warmth, and then I'm assessing for edema here. Okay, and now I check for pedal pulse, nice and strong. I'll check this one. Okay, now I feel a pedal pulse, nice and strong. Now if I couldn't feel that or I had difficulty, I might back up and try the posterior tibial pulse, which is right on there. And I can feel that as well. All right, now I'm looking at the color. It's a little pale, he's definitely cool. Cap refill is brisk. Again, you need to compare. Check sensation here. Which toe am I touching?
A little toe.
Right, and which one here?
Big toe.
All right, and here?
Big toe.
And here?
Little toe.
Great. Now I want to assess his strength, so I'm going to go right to the bed so I can see that it's equal. Can you push down as hard as you can? Good. Now pull back, toes to your head. Good. Is there any tenderness here at all?
No.
All right. Now I can tell that his strength is strong and equal bilaterally. All right. Now the last thing I'd like to do is listen to posterior lung sounds. Now he's able-bodied, able to sit at the side of the bed. That's the most ideal situation. Although not everyone will be able to do that, so it's perfectly acceptable to have him roll from side to side and listen to posterior lung sounds. Some patients also will be able to sit up in bed. I'd like to get him up to the chair for a meal, so I'm going to have you sit at the side of the bed, Jim. Help you to. Okay. Now I'll go right behind so that I'm square. Now there's 10 spots posteriorly. We'll have you take some nice deep breaths again, Jim, in and out. Six. And I start to move down. 7, 8, and 10. Okay. Now I'm going to listen to lateral lung sounds again from side to side. Deep breath. Good. Now there are 2 more lung assessment things that I'm going to talk about. One is the anterior posterior diameter of the chest. This can indicate a chronic disease like COPD. What we should see is we're looking at, okay, side to side should be compared to here. This should be anterior posterior should be half to 1/3 as wide as what he is here. Now I would say that's about 1/3 to what this would be. Okay, so that's a normal finding. Some people with chronic disease, they'll have a barrel chest, so it might be more equal. You might see a more broad chest, but it would be more equal to his side-to-side diameter. The other thing we can do is assess excursion, and what that is to see if there's symmetry in both of his lungs when he inflates. Okay, so I put my thumbs together. Okay, can you take a nice deep breath, Jim? Okay. And I should have an equal fanning on each side. Okay. Then I was to assess how he tolerated that. Did you feel any dizziness or anything when you changed position?
No.
All right. Now, if I'm going to lead him at this point, I'll help him to lie back down again. And then we always want to make sure his side rails are up and the call light is in reach and his bed is in a low position.